Hi, this is Brian Kim. I'm going to share with you case number 85 in the Best Way to Do Cataract Surgery series. This is a patient with a big pupil and an average lens density, and I'm just going to show you systematic lens disassembly using double chop, cross chop, and mechanical fracturing. You can see this patient has a pretty large pupil. I'm holding the eye steady with the cotton tip and then using the corneal marker to help me center and size my rhexis. I'm making my paracentesis incision. As I was about to make my paracentesis incision, the patient suddenly moved and it caused a partial thickness corneal mark there. And so I didn't want to go through that area. And so I had to make a separate incision. This goes to show there's no such thing as a routine cataract surgery. You can have the case going smoothly and suddenly the patient moves and now you have a slightly partial thickness corneal laceration to deal with. Thankfully in this case, it wasn't through and through and didn't lead to any complications. But these things happen with cataract surgery or any surgery. I'm injecting intracameral lidocaine and then dispersive viscoelastic. This is a triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove, tunnel, and then enter. Push some more viscoelastic after I make my incision to flatten the anterior capsule. I go in with the teeth of the forceps sideways and with the teeth pointed downward, I puncture. And when the puncture doesn't quite go straight towards me, with the teeth closed, I just very gently manipulate the tear towards me. I grasp the right side edge of the tear and I go around, starting the flap. I try to follow the corneal mark that I made previously, which will hopefully allow me to achieve a well-centered incised rhexis. This is the capsulorhexis hydrodissection technique. I place the cannula out underneath the rhexis edge contra-incisionally, point the tip down towards the nerve, push and get a nice fluid wave, decompress on the left side. I tried to spin it on the right side. It didn't want to spin as well. And then I'm just going around and starting to spin the lens there. Irrigate the surface of the cornea to remove the surface oils and debris, adjusting the sleeve accordingly. Lifting the incision with a chopper, going in with irrigation off to minimize Descemet's trauma, removing the surface epinuclear material, placing the chopper under the rhexis edge contra-incisionally, placing the phaco tip vertically sub-incisionally, crushing and bisecting the lens, placing the chopper around the right heminucleus, pulling it centrally towards the phaco tip, and crushing the right heminucleus. That is the double chop and cross chop. Grasping the first quadrant with the phaco tip with aspiration and vacuum, crushing the lens between the chopper and the phaco tip and emulsifying the lens piece, hooking the second quadrant with the chopper, pulling it up, crushing it between the chopper and the phaco tip, and then emulsifying the lens piece. Rotating the second heminucleus in front of me, placing the chopper around the lens piece, crushing it against the phaco tip, and then emulsifying that third quadrant, lifting that fourth quadrant up, with the phaco tip, and then crushing it between the chopper and the phaco tip, and then emulsifying the lens piece. So as you can see, that was a pretty average lens density using mechanical fracturing forces, double chop, cross chop, and the endonucleus was removed pretty efficiently there. So I removed the epinucleus, and it tumbles out. I take the chopper out, push BSS in, take the phaco tip out, and go in with the INA handpiece. I start to go around with the INA handpiece, removing any cortical material there. It's pretty clean. I switched to polish mode fairly early, polishing under the rhexis edge, removing any potential lens material as well as the lens epithelial cells. Polish the subincisional posterior capsule as well. There's some fine material there. I'm using the BSS cannula to pulse the subincisional space. As I pulse the subincisional space, you can see the subincisional cortical material starts to loosen up. I use the INA tip to remove that material. Fill the capsular bag with cohesive viscoelastic, polishing under the rhexis edge with the sweeper, and at the same time removing some of that cortical material that was in a subincisional space. And then polishing on the right side. You can see, especially in these really big pupils, how really nice the polishing does. It really makes a big difference in polishing underneath the anterior capsule edge there. So I go in with a single piece acrylic intraocular lens into the capsular bag, placing the leading edge into the bag. As the lens unfolds, I quickly transition to the INA, go in with irrigation off, activate irrigation, making sure both haptics are off the optic, getting under the optic, tilting it and rotating it 90 degrees clockwise, removing all the viscoelastic from within the bag and under the lens, polishing under the rhexis edge as well. I'm going to do that by switching to polish mode and then polishing under the rhexis edge some more. Switching to polish mode to remove some more of that fine lens material that's under the rhexis edge, and then I'll hydrate my incision. So you can see this is a pretty standard lens, really big pupil. With these big pupils, you can really see exactly what I'm doing with the double chop and cross chop maneuvers. You can see how clean the anterior capsule is with the polishing maneuvers. And so again, this is a pretty standard technique for this type of lens, fairly routine. You could see the CDE is low in these cases. And by doing it this way, I do really feel like patients have clearer corneas after surgery. Patients are able to see better, even day 1 after surgery, even day 0 after surgery. And I think it has led to definitely a more satisfied patient, definitely practice builder. Whenever you reduce ultrasonic energy, I really don't care what people say about, well, you can use as much phaco energy as long as you don't direct it towards the cornea. I think that unfortunately you're not able to always guarantee that the cornea is perfectly protected every time. And so by minimizing ultrasonic energy, I really feel like it's the best way to do cataract surgery. So I hope this was helpful to you, and I thank you for your attention.